Dr. Arundhati Dwivedi.
Good evening to all the judges and the audience. Today I shall be presenting my work on visual and surgical outcomes of Descemet stripping automated endothelial keratoplasty with either IOL exchange or the secondary IOL implantation. I have no disclosures to make. So as we all know, the ill-fitted anterior chamber intraocular lenses and the subluxated intraocular lenses, if left in the anterior chamber, can eventually lead to bullous keratopathy. The most common treatment method in the past was the penetrating or the full thickness keratoplasty, but in view of the long-term sequelae and risk factors of graft rejection and post-operative astigmatism and relatively longer period of visual recovery, we now have shifted slowly towards Descemet stripping automated endothelial keratoplasty. Correction of aphakia can be done concurrently or in a staged manner along with the DSAEK. The challenges faced in implanting an IOL in DSAEK is that there is an escape of air which occurs from the anterior to the posterior chamber due to lack of the diaphragm effect. This in turn causes iridocorneal adhesions and the high intraocular pressures and the secondary glaucoma. So based on the sulcus support, the IOL can be either placed in the sulcus or it can be placed either in the anterior chamber. So the aim of my study is to identify the indications, postoperative visual and surgical outcomes of cases which have undergone DSAEK with secondary IOL implantation at our institute during a period of 2 years from 1st January 2021 to 31st December 2022. It was a retrospective type of study. Coming to our results, we had a total of 105 eyes, of which 46 were female and 59 were male, and the mean age group ranged from 18 to 86 years. Out of these, 54 patients were implanted with ACIOL, accounting for the most part of the type of IOL implanted along with the DSAEK, followed closely by 33 eyes being implanted with iris claw, followed by 17 with PCIOL, I mean the posterior chamber intraocular lens in sulcus, and only we had one patient which has been scleral fixated IOL was done along with the DSAEK. Moving on to the indications for DSAEK with IOL exchange or the implantation, as we can see, pseudophakic bullous keratopathy was the most common indication, accounting for about 54%, followed closely by aphakic bullous keratopathy, accounting for 37%, and then failed grafts accounting for 8%, and 1% to 2% of the patients had Brown-McLean syndrome. So coming to the graphical representation of our results, as we can see, about 40% of patients had both the uncorrected and best corrected visual acuity at post-op 3 months follow-up, much better and significant compared to the preoperative uncorrected and the best corrected visual acuity. Coming to the comparison of visual outcome at various visits, as we can see at post-operative day 1, the uncorrected visual acuity was a little worse when compared to the subsequent visits. This can be explained by the intra or the immediate post-operative corneal edema and the anterior chamber inflammation that might follow, which usually resolves over a period of time. Coming to the comparison based on the type of IOL implanted, the iris claw lens had better visual outcome comparatively as compared to the anterior chamber and the posterior chamber intraocular lens. To the best of our knowledge, ours is the only study which compared outcomes of DSAEK based on the type of IOL implanted, limitations being the retrospective nature and a very short follow-up. So I conclude by saying that PBK was the most common indication in our study for the DSAEK with secondary IOL implantation, and iris claw is a very good alternative to ACIOL during DSAEK with good visual outcome and comparatively lesser severity of glaucoma. In the interest of time, I have not mentioned glaucoma here, but we had seen that So we had seen that the glaucoma incidence was surprisingly lesser in iris claw lens compared to anterior chamber intraocular lens, but because our follow-up period was only 3 months, we didn't include the results yet here.
Why this iris claw lens was better than posterior chamber lenses?
Because we had placed it retropupillarly, not in the anterior chamber. It was retropupillarly fixated
But still posterior chamber, why it should be better? Any reason for that?
Because there is no crowding of the anterior chamber angle and there is no crowding of the space. in the anterior chamber, and the lenticule will fit better, and the rate of detachment also, the graft detachment, I mean the post-operative detachment also has very less chances in iris claw if it is placed retropupillarly, I mean, compared to anteriorly placed.
So did you see any cases of uveitis after that?
Yes, we did have, but as I said, we were primarily looking at glaucoma, graft detachments, and glaucoma, graft detachment, and graft failure. So we didn't specifically
will not
look at.
incite a rejection reaction.
Yes, it will surely.
So was the DSAEK and the IOL exchange at the same setting, or there was some sequential procedures also? It was in the same setting.
No, doctor. We have included only
Only the
cases
same
which have undergone simultaneously at the
Any
same setting.
intraoperative complication?
Yes, we are also looking at the intraoperative complications like synechial lysis and the iris adhesions and all this, and also how many cases we needed vitrectomy, or were there any retrocorneal membranes or adhesions and all this.
So do you recommend which is better, subsequently or at the same sitting? You have not
Same seating will be better, sir. It depends on multiple factors though. Like if the patient from preoperatively has glaucoma, then I will have to think. Even if the iris is good, then I will not go for ACL, then I will put iris claw and all. Or SFIL maybe.